Okay, so we're going to begin today with this question. So we talked about hematocrit and packed cell volume. So what if Liz has a high hematocrit reading? What does this mean? We should have 6 responses. Someone's is not working. Okay, the correct answer is she has polycythemia, not that she's hemorrhaging. If she's hemorrhaging, that means she has blood loss. That means she loses red blood cells. So her red blood cell volume will come down. So she will have a low hematocrit in that case, okay? So she has polycythemia because what does high hematocrit means? That when you take the test tube and you look at this red cell column, this is a column, this is more than normal. So instead of being this much, this is more than normal. And in a woman, remember, it was about 42 millimeters. So more than normal meaning you have more red cells. And what is the term we use for more red cells? Polycythemia, okay? If she was hemorrhaging, actually her hematocrit would have been here, much lower, okay? Now we'll move on to white blood cells, and we have a wide range actually of a normal white cell count. It's from 5,000 to 11,000. Again, labs vary a little bit, they may go from 4,500 to a little bit over, but this is approximately the range that we see white cell count in. And they are classified into 2 types. Those with granules are known as granulocytes. Those without granules are known as agranulocytes. Okay, granulocytes and agranulocytes meaning without granules. So let's look at the granulocytes first. And you'll notice that they all have the word "phil" at the end of it. We have neutrophils, eosinophils, and basophils. And they're they're given this name, neutrophils, eosinophils, basophils, depending on the color that the granules take up when you stain with common hematoxylin, eosin, or white stain. So neutrophils, the granules are more or less kind of colorless granules. So when you look at the granules, they are more or less colorless, sand-like, maybe very, very light blue. But I like to call them colorless. You can see that they're granules, but you can't really tell what the color of the granules is. Eosinophils are cells, white blood cells, where the granule color ranges from pink to a bright red. So they go from a light salmon pink to be really bright red. So you can have intermediate colors in between, an orangish red, orange, again, depending on how well it takes the stain and how you're doing it. Basophils, the granules are purplish blue in color, purplish blue in color. In all these 3, the granules are well defined, and if you look under the microscope, you'll be able to identify these cells based on just looking at them. Now that's the numbers that you commonly see. Neutrophils are the majority of the white cells, usually about 55%. Eosinophils are about 4%. Again, there's a range, 4 to 8% sometimes, some people say. Basophils are 1% is about the maximum you can have basophils. If you count 100 cells, you're lucky if you really find 1 basophil, okay? Now you see the letters PMN written in front of neutrophils. That's because that stands for polymorphonuclear. PMN stands for polymorphonuclear. Very, very often when you get a blood test done, they might write PMN 25%, PMN 55%, Why is it called polymorphonuclear? Poly means many, morpho means structure, and nuclear means the nucleus. So in other words, the nucleus has many, is of varied structure. And that is because when you look at a neutrophil, so if I draw a neutrophil for you like this, that's the cell membrane, and this is the cytoplasm inside. The nucleus, instead of being a single nucleus, the nucleus is actually lobed. It can be just bilobed like this, just two lobes, or you might have one where the nucleus has 3 or more lobes. So there may be 3, there may be 4, there may be even 5. So it can go from 2 to 5 lobes. So can you see that? So that's why you find many different types of nuclei in this. And then here is where you find those granules. So the granules are colorless. And this is where you'll see, like I said, light blue to colorless. Okay, so this is where you'll see the granules. So that's why we call it a granulocyte. In women, what you find in a certain percentage, about 1 to 3% of the cells, of the neutrophils, you will find attached to the nucleus, and I'll draw here, to any one of the lobes of the nucleus. So let's say we have 3 lobes. You'll find a little drumstick-like projection like this. This is known as the Barr body. This little drumstick-like projection is known as the Barr body, and it represents one of the X chromosomes. Women have 2 X chromosomes, so this represents one of them. It is not seen in all the neutrophils, just seen in very few of them, about 1 to 3% of the neutrophils, and it's the Barr body, and seen only in women because it represents the second X chromosome that they have. Okay? Now, what is the function of neutrophils? Neutrophils are large cells with a lot of cytoplasm. So you can see the cytoplasm here. There's quite a lot of cytoplasm. They are phagocytic. So they sort of wherever, and especially phagocytic wherever there is bacterial infection. In fact, if a bacterium enters the body, the neutrophils go to that site. They phagocytose the bacteria. They die in the process. And often you see, when you get boils on your face, on acne, and you have little pus points over there, that's really dead neutrophils. So that's what they end up forming, pus. So they're very active in bacterial infections. When anyone has a bacterial infection, you'll tend to see that the neutrophil count goes up. And because they're actively phagocytic, but they die when they engulf the bacteria. Okay. The second one, eosinophils. These are active whenever there is an allergic response or a person has a parasitic infestation. So then the eosinophils tend to increase in number. So in allergies, and parasitic infestations, like someone has worms, tick-borne diseases. So what happens is actually those granules get liberated and they actually stun the worms. And eosinophil count tends to get very high in people who have seasonal allergies. So you usually tend to find a high eosinophil count. Okay. Basophils, they take part in inflammation. Their granules are very similar to mast cells, and they liberate histamine and heparin. So the granules in basophils liberate histamine and heparin, take part in inflammation. They also take part in allergies, but since eosinophils are much more, eosinophils become more important when allergic or parasitic infestations are there. You very rarely find a very, very high basophil count. You're more likely to find a high eosinophil count. Agranulocytes are the ones without granules, and these are lymphocytes and monocytes. Lymphocytes, as you can see, are the second largest of the white cell population, around 30%, maybe a little bit over. So they have no granules. In fact, they have a nucleus, a large nucleus with very little cytoplasm. A lymphocyte has very little pale bluish cytoplasm. Sometimes you may not even see the cytoplasm. It may just be a rim just a thin rim around. So usually when you look at lymphocytes, when you look at lymphoid organs, you're only looking at the nuclei, and that gives it that real deep blue purplish color. When we do the lymphoid system, we'll do them in more detail, but lymphocytes take part in the immune response. They produce antibodies. They take part in something known as cell-mediated immune response. And they have other functions. We have natural killer cells also, which are lymphocytes. So we'll do them in more detail when we do the immune system. But for now, you can remember that they take part in the immune response, in the more specific immune response, some of it in the non-specific as well. Monocytes are the largest of the white blood cells. Really large cells. Very big. Lot of cytoplasm, so they are also phagocytic like the neutrophils. In fact, they go into the tissues and get converted into macrophages. So these neutrophils get converted into macrophages in the tissues, and you know macrophages are phagocytic in nature. And they too actually have a varied nucleus. We commonly say that it has a kidney-shaped nucleus, something like this. But quite often you will find that the nucleus may be of a different shape. It may look flower-like. So this is the nucleus. So here also the nucleus can be quite varied. Their cytoplasm has no granules, very light blue staining. And sometimes you might see little holes in them, and it looks like gives a Swiss cheese appearance. But very, very large cells. Then we have some terms that we use with white cells. Whenever you have the word pinia, pinia means a lowered count or less. It really means less. So, you know, someone has osteopenia, means they have less bone. The bone density is low. So, leukopenia is a condition where the white cell count is low. And this could be due to any reason. Maybe the bone marrow is not producing enough white blood cells. You know, that could be a possible reason. Leukocytosis is a condition where the white cell count increases in number. You usually see leukocytosis whenever there is any kind of infection in the body. If there's a bacterial infection, you'll see neutrophils. If, you know, depending on the kind of infections that you find, usually viral infections, you'll find lymphocytes have increased in number. So that's a normal thing to see whenever there's an infection, because the body produces more of these cells to fight that infection. So that's leukocytosis. Leukemias, on the other hand, are where the white cell count is increased, but this is an uncontrolled increase, and there's no need for it to increase. So these are cancers. Based on the type of cell you see, you define the leukemia, such as you might have lymphoblastic leukemia, or monocytic leukemia, or lymphocytic leukemia. And again, it could be an acute kind of leukemia or a chronic kind of leukemia. Acute leukemias are usually a little bit more dangerous than chronic ones. Now here's an image showing you white cells, and we also look at platelets. So let's look at the granulocytes first. So here is a neutrophil. So this is a neutrophil. This is another neutrophil. So these are two nuclei. You can't see the little band which connects them, but usually you'll have a small sort of thin segment of nuclear material connecting the two. Here you can see three lobes. So you can see here and here. That's the band connecting the lobes. You can see the granules up here, not well defined, but kind of looking sandy. Large cell. This is an eosinophil. An eosinophil quite commonly is described as the nucleus having two lobes, so you know it looks like a sunglass, but that's not always necessarily so. An eosinophil may have more than two lobes. It may look like a neutrophil, may have three or four. But how you'll differentiate it is that, can you see the granules extremely well defined? Here you can see that the granules are red, but they may be pink, or, you know, light orange or orangish red, but the granules are very, very well defined. So you'll always be able to make that out. Here's a basophil. So again, look at the granules. They are purplish, and in fact, they tend to cover the nucleus. So you can barely see the nucleus, but you can make out the granules quite clearly. So these are the granulocytes. Agranulocytes, here's a lymphocyte. Notice this is the nucleus, large nucleus, and just this little rim of cytoplasm, light blue in color, no granules. And here's a monocyte. So can you see how big this monocyte is? Look at this nucleus. It's not typically kidney shaped. Looks, can't really describe the shape. But here is this light bluish gray cytoplasm, and you can see these tiny little holes in it. And so sometimes you can see these, so it gives it a little Swiss cheese-like appearance. The next cell we are going to do are platelets, and here are what platelets, so platelets are not really typical cells in that they don't have a nucleus and cytoplasm. They're called like cell inclusions. So they are really flower-like structures, and they usually kind of tend to, you see many together. So here are the platelets up here, flower-like structures. Now let's just do a little review. Someone who has an acute bacterial infection, what are they likely to show? Yes, increased neutrophils. Very good. How about this one? So James unfortunately got bitten in the Appalachian Mountains and this developed Lyme disease, which you may have all heard of. So what do you expect to see? Very good, yes, increased eosinophils. And here's another one. Would it be possible to tell the sex of a person by studying a peripheral blood smear? Yes, very good. Because if you see the bar body, you can definitely tell that this is a woman. If you don't see it, it could be either male or woman. But if you see the bar body, you can definitely tell that this is a woman, right? So you can tell the sex. So let's look at platelets. Again, like I said, they are cell inclusions, flower-like structures. The count is usually 250,000 to 350,000 per cubic millimeter. They are important because they take part in clotting of blood. So what they do is if there is a tear in the vessel wall, they go and aggregate at that point and form a little platelet plug. So they stop the bleeding for some time till the clotting process begins to occur. They are under the control of a hormone which is produced by the liver called thrombopoietin. If you remember, there was something called erythropoietin produced by the kidneys for red cell manufacture, right? For platelet manufacture, there is a substance called thrombopoietin, which is produced by the liver. And if you remember, right in the beginning, also I mentioned the liver produces clotting factors, like fibrinogen. So this is one way to remember, since this takes part in clotting, thrombopoietin is also produced by the liver. Another name for platelets is thrombocytes. So therefore, when there is a low platelet count, it is known as thrombocytopenia. A low platelet count is called thrombocytopenia. Now, since platelets tend to aggregate, or collect wherever there is a vessel wall tear, we kind of use this knowledge when we prescribe certain drugs. People who are prone to forming clots in the body, like, anyone who's had a heart attack because they have cholesterol plaques in the body, you often know that they've given aspirin. They call it a blood thinner. The way aspirin acts is that in a normal blood blood vessel, so if you have a normal blood vessel, it's like a normal tube. Like imagine plumbing, like a normal good pipe, which has no collection, it's smooth inside. So in a normal blood vessel, the endothelial lining is smooth and blood flows freely. In someone who has a plaque, a cholesterol plaque, so can you see here the blood vessel wall becomes rough. It's almost like, imagine if you have an old pipe which has some kind of encrustation on it. What does it do? As water passes through, it tends to kind of gather more, and the crust kind of gets more, it gets bigger and bigger. The same thing actually happens in our blood vessels. So when you have a cholesterol plaque like this, it makes this area rough. So as platelets are flowing by, what happens is they come and stick to this area. And when they come and stick to this area, they drag more platelets. So can you see, when more and more will drag, at some point it can actually block the whole blood vessel and you can end up with a clot there, right? So what aspirin does is it prevents the aggregation, the tendency of platelets to aggregate together. So that's how it acts like a blood thinner. It's not that it actually makes the blood more liquid, but it prevents the platelets from getting together or aggregating together. So, of course, they have to take other medications to make sure that they don't have the plaque growing bigger. So now platelets will not come and stick on this cholesterol plaque. So that's how that's how aspirin is used for people who are prone to forming clots. So here is a slide showing you the summary of blood components. So I kind of won't go through all of this. So you can see this, a hematocrit, when you do, you can see 55% is plasma. Of this, 45% are cells. Notice how most of it is red blood cells. So you can see this part here. This is the hematocrit that we see. And when we do a complete blood count, at some point or the other, you all have had a complete blood count done, right? So you get your red blood cell count done. You get your white cell count done. You get the hematocrit done. You get what is also called a differential white cell count, also known as a differential white cell count. So that's known as DLC, differential white cell count. And the reason you want to do a differential white cell count is that if I do somebody's white cell count and I see that their white cell count is 8,000, and I say, oh, that's fine, they are within normal limits, because, between 5 and 11 is normal. But their white cell count may not have increased too much, but they might have some sort of an allergic response, and their eosinophil count might be more than normal, right? Remember I said in your notes you've been given the ranges between around 4 or 8. Suppose the eosinophil count is more, then you want to know whether they're suffering from an allergy or not. So when you do a differential count, you count 100 cells. So you can tell by this whether the number of neutrophils, lymphocytes, basophils all fall within normal range or not. So as just to give you an example, if I did a differential count of somebody, and let's say I got something like this. Neutrophils is, let's say, about 45. And I say eosinophils is 24. So let me make this 25. 70. Lymphocytes is about 28. Monocyte is 2. And basophil is 0. Okay? So can you see here that a eosinophil count is much more than normal? Remember, it was 4 to 8%, maximum 10%. So 10% means you count 100 cells, you should find a maximum of 10. This person has 25. So can you see more than normal? So by a differential count, you can tell what exactly is going on with them. So if they had a high neutrophil count up here, then you can say they're probably suffering from a bacterial infection. High eosinophil count, they're probably suffering from an allergic or parasitic infestation. So a differential count gives you more information, okay? So you do that. You also do in a complete blood count, you also do platelet count to see if their platelets are within normal. So here you can see the various ranges which are given up here. And every lab kind of differs a little bit, okay? Okay, now let's answer this question. Which of the following conditions might cause thrombocytopenia? Very good. Liver disease, which is why you'll find that somebody who has liver disease, usually apart from all the other problems that they always have bleeding tendency, because they are not forming, if the liver's disease is not able to do its job properly, so it's not forming clotting factors, it's not also releasing thrombopoietin, which means platelet count is low, and anyone with low platelet count will also have bleeding problems, right? So that's how you see what happens in liver disease. So these are some of the kind of questions you'll be asked where you got to apply your knowledge. Now let's look at clotting of blood. So clotting is really a big topic by itself, but we'll kind of break it down into a little shorter version. So initially, whenever there is a tear anywhere, a blood vessel wall tears, the first reaction is that it goes into a spasm. The sympathetic nervous system causes the blood vessel to constrict. And so that is called vasospasm, or also known as vasoconstriction. Sometimes this vasoconstriction can be really useful. You know, somebody might have had an automobile accident and let's say a huge artery is severed. They could bleed profusely, but sometimes it just so happens that the body causes that vasoconstriction, so they bleed less than they would have bled had that vasoconstriction not occurred. So the first thing that happens is vasospasm. And then because the blood vessel is ruptured, that area becomes rough because the collagen is exposed. So platelets now begin to come and collect at that area, and they seal the tear. So they form a sort of soft clot. And after this, again, because of the exposure to collagen, there's a kind of reaction that comes about, which is known as a cascade reaction. That means one substance, one factor becomes activated, causes the activation of another factor, and it, like a domino effect, it goes on. So there are many clotting factors, about 13 clotting factors, but the important processes that are needed for clotting to occur is, the first thing is that this substance called prothrombin, which is again produced in the liver, this gets converted into thrombin. Prothrombin is inactive, and then through a series of activation, this prothrombin gets converted to thrombin. And then in the presence of thrombin, fibrinogen gets converted to fibrin. Now these fibrin threads, they kind of are present over the platelets, and as blood is flowing by, other cells also get caught in that. So from a soft little platelet clot, you now have a much more well-defined sort of clot that is formed, which can prevent further bleeding. But since it has fluid in it, you want to make it even stronger. So what happens is, like a sponge, the clot retracts. So it squeezes out all the plasma. So that's known as clot retraction. So that clot becomes even more firm. And then once the job is done, bleeding has stopped, you don't want that clot to remain, because if it remained, it could be flushed by the bloodstream and go and lodge somewhere else and, block a small blood vessel or a capillary. So what happens is the clot actually undergoes lysis or dissolution. It kind of dissolves. And that is known as fibrinolysis. So the fibrin gets lysed, and this is brought about by plasmin. And actually there's something known as plasminogen, which gets converted into plasmin. And plasmin is the one which causes clot lysis. I don't know how many of you have heard of something known as TPA. People who have strokes, especially strokes are like a brain attack. If the stroke is because of a clot in the brain, they are given this TPA. TPA stands for tissue plasminogen activator. So the reason they're given that is that if they've had a stroke, it's because a small blood vessel there's a clot which is blocking that, and the nervous tissue is not getting the blood supply. So when you give them TPA, the plasminogen is activated, plasmin is released, and it can dissolve the clot. So that, further damage does not occur, because that little clot could break off and go to other areas and become emboli. Now, vitamin K is very important for clotting factors. So vitamin K in our body is used in the liver and it helps to form clotting factors. We make use of this knowledge by giving, whenever in people who have the tendency to form clots, I already told you, one of the things you give them is aspirin. Another substance you can give, another drug you can give would be something which interferes with vitamin K doing its job. So they are kind of the vitamin K antagonists. Okay? So certain drugs like Coumadin and so on are used to, and they are called blood thinners. And again, the reason is that they don't make the blood any thinner. They just prevent clots from forming by acting differently, either platelet aggregation or preventing clotting factors from being formed or being vitamin K antagonists. Okay? Streptokinase also is something which acts differently. It's something which is given usually after heart attacks, again to dissolve clots. So it acts very much like plasmin. So streptokinase is given where you want to dissolve clots. So clot has already formed, so now you want to dissolve it. So this is something like this. So if you hear about it or read about it, then now you should be able to kind of connect why this drug is being given. So let's look at this video on clotting.
Usually, every time you have a cut or bruise, your blood clots to stop the bleeding. Clotting is a complex process, and there are four main things that make it possible: platelets or cell fragments, clotting factors, which are special proteins, fibrin, which is a protein mesh made up of a special kind of clotting factor, and finally, other cells, like red and white blood cells. Because clot formation is so important, platelets and clotting factors are always available, floating around in your blood. Now, let's talk about the four steps involved with forming a blood clot. When there is a tear in a blood vessel, the first thing that happens is that the nearby platelet into the sides of the hole in the blood vessel. For small hole, enough plates usually stick together to form a temporary plug. But a platelet plug isn't strong enough to block the opening for long, so it must be otherwise the blood flowing past the hole could wash the plug away. These other materials are called clotting factors. As the clotting factors float by air, they become activated or turned on and add themselves to the platelet. A special kind of float by air, they become activated or turned on and add themselves to the platelet. A special kind of clotting factor can weave itself together with others of the same kind and form tissue. This web acts like glue and holds the platelets and the other clotting factors together, creating a blood clot. Blood cells can also get caught in this web and help reinforce the clot. It gets stronger and starts to pull the edges of the hole in the blood vessel together. After the clot has formed, it stays in the hole until the tissue is repaired. When the clot is no longer needed, your body dissolves it.
Now, you all may have heard of a known as hemophilia. You've heard of this is due to lack of a clotting factor, and it's clotting factor 8. And this is something that is carried on the X chromosome. So it's a sex-linked genetic disease. So you lack a clotting factor. So when they lack this clotting factor, these people obviously are prone to bleeding very often. Remember, this is very different from thrombocytopenia and clotting factor. Say the liver is obviously are prone to bleeding very often. Remember, this is very different from thrombocytopenia and clotting factor. Say the liver is damaged. In all those three cases, you still bleed, but the reason why you're bleeding is very different. In hemophilia, it is because you lack this clotting factor and you lack the gene for producing that clotting factor. In thrombocytopenia, you're lacking platelets. In a liver disease, first of all, you don't produce thrombopoietin, so platelet number is reduced, plus you're not forming clotting factors like prothrombin and fibrinogen and so on. Okay? Yes?
Is there any medication that I can
Well, you cannot give them any medication to help them. What you have to do, they have to get regular blood transfusions, because you can't do anything with their genes. So you can't do that. And someone who has, thrombocytopenia, you find out what is the cause of thrombocytopenia and you can, take care of that. But not for this. You have to give them regular blood transfusions. Make sure that they don't, they avoid getting bruised easily and so on, because if they get bruised, they tend to bleed for very long. And they're, sometimes, just a little hit would cause bleeding into their joints and so on. So you have to remove that. So it's kind of treatment throughout life, but you can't give them one drug and say, be done with it. Okay. So here, let's look at actions of blood thinners since we've been doing this.
Is the brand name for warfarin, an anticoagulant or blood thinner, which was approved by the FDA in 1952. Warfarin is a prescription medication which is available as a generic drug and under the brand name Coumadin, coagulant, or blood thinner. It helps take from clotting. Here's how it works. Vitamin K helps with bleeding through clot formation. Sometimes, though, clots can form too readily and block blood supply to vital organs. When warfarin of vitamin K, bring in thinner blood, fewer clots. Warfarin is often prescribed to people who have suffered heart attacks. It can be used to prevent the formation, which is blood clot, and prevent thrombosis, which is a clot in the veins. Patients with rapid or irregular heartbeats and those who have artificial heart valves may also take this medication as a precautionary measure. Warfarin can be taken.
So you can see how it antagonizes the action of vitamin K, and that's why it's... Okay, so let's answer this question. Amanda cuts her finger, she's bleeding. Which is a way that hemostasis in this case, and also homeostasis is where you maintain blood volume, the body will not use that way. Okay, producing erythropoietin. There's no point producing erythropoietin because first, when you produce erythropoietin, it takes a while. Second, even if you did produce erythropoietin, what is it going to do? Just increase your red cell count. That's not going to help. She's bleeding, right? So what do you want to do? Stop the bleeding. So you don't want to produce more red cells at this point because it's going to take a while. So first, this vasospasm is going to occur. You are going to have platelets come to that point. And clotting will occur. So the clotting mechanism will take place. Okay. Producing erythropoietin is not going to stop her bleeding at this point because first you don't want to produce more red cells at this point because it's going to take a while. So first this vasospasm is going to occur. You are going to have platelets come to that point and clotting will occur. So the clotting mechanism will take place. Okay. Producing erythropoietin is not going to stop her bleeding at this point because first it's going to take a while for erythropoietin to go in and stimulate the bone marrow. When it does, red blood cell count is going to increase. And that has nothing to do with stopping bleeding. Okay? Now let's look at the next topic, which is blood groups. And if you remember, right when we started, we were talking about antigens and antibodies. So antigens were known as agglutinogens and antibodies were called agglutinins. So antigens are present on the surface of a cell, antibodies are present in the plasma. In blood groups, you have antigens which are present on the red cell surface, red blood cell surface, and based on which antigen is present, that's how the blood group is determined. So we have two types of grouping that we use. There are many actually, but these are the two main ones that you're responsible for. One is called ABO typing, where you have antigens A or B, or you may have both together. So you may have A and B antigens, okay? Or you may not have any antigen. So we'll see how you how you will describe what the blood type is. So based on whether antigen A is present, whether antigen B is present, whether both A and B are present, or no antigen is present on the surface of the red blood cell, we type the blood as A, B, AB, or O, and that's known as ABO typing. And then we have another one called RH or rhesus typing, based on first being discovered in the rhesus monkey, which has again a number of antigens, but the common one that we take is antigen D. So if antigen D is present on the red blood cell surface, we say that the person is positive. They are RH positive. So if antigen D is present, we say they are RH positive. If antigen D is not present, we say they are RH negative. So both this ABO typing and RH typing occur together in our blood. So you can have a person who is A positive or A negative, or B positive or B negative, or AB positive or AB negative, or O positive or O negative. Okay? Now the other thing to remember is that in the ABO typing, if they have a particular antigen on the surface of their cell, they have the opposite antibody in their plasma. This is something that is just there, and they are born with it. Okay? Because an antibody is against the antigen. So if you have antigen A on the surface of your cell, you do not want antibody A to be present in your plasma, because antibody A means it's against A. So it will attack it, right? So when you have one antigen on the surface of your cell, you have the opposite antibody in your plasma. So if you have two antigens or both A and B, then you will not have any antibodies, because they can destroy the cells. Okay? So we'll see how that is, how that works out. In the RH typing, however, whether you have the antigen or you don't, in other words, whether you're positive or you're negative, the antibody is not pre-formed in your plasma. So in either case, whether you're Rh positive or Rh negative, you do not have any antibody D in your plasma when you're born. You will only form it if you get a mismatched transfusion. Okay? So what you take away from this is that antigens determine what is your blood group. They are present on the surface of the cell. In the ABO typing, antibodies are present in the plasma, and they are always opposite to what the antigen is, so that they don't destroy the antigen. In the Rh typing, there are no antibodies present in your plasma at birth and throughout life, unless you get a mismatched transfusion, in which case the body begins to form the antibodies. Okay? So let's look at this one. So let's look at the ABO and Rh typing here. So let's first just do ABO. So let's say this is somebody has antigen A on their surface of their red blood cell. They will have antibody B in their plasma, because B cannot attack A. So their blood group is A. They are born with this. If they have antigen A, we say they are A group, and automatically you know that they have antibody B in their plasma. If they have antigen B, they'll have antibody A. Okay? Got that? If they have both antigen A and antigen B, then in their plasma they will not have any antibodies. Why? Because it would attack, if you had antibody A, it would attack the antigen A. If you had antibody B, it would attack antigen B. So if you have both, then both would be attacked. So you don't have any antibodies in their plasma. Okay? So when I say it is present on the surface of the cell, so imagine all these red cells like this. There's a little thing like this. So this is A and this is B. A and B. Therefore, you cannot have antibody A or B, because it would attack this, and whenever an antibody and an antigen react together, you get what is known as hemolysis, where the red blood cell will rupture. Okay? So you don't have any antibodies in the AB group. In O group, you do not have, you call it O group because there is no antigen A or antigen B. So you say it's O group. So now it is safe for them to have antibodies in their plasma. So anybody who's born with O group has no antigens on the surface of their red cell, but they have antibody A and antibody B in their plasma, because they have nothing to attack. So it's safe for them to have that. Okay? So that's how they are born. Like I said, in the Rh group, if you have the antigen, you call it Rh positive. If you don't have the antigen, you call it Rh negative. In either case, there are no antibodies in the plasma. Okay? So let's look at some questions here. Jennifer's blood group is AB positive. And what does this mean she has? Okay, come on. Very good. Yes, she has no antibodies in her plasma. So we know she's AB positive. So that means she has antigen A, she has antigen B, and she has the Rh antigen. And we know when you have A and B, then you cannot have antibodies in your plasma, and the Rh positive or negative in any case doesn't have. So this is the only answer which is correct, because we can't say she has both antigens A and antibodies, and she does not have antibodies A and B, and she does have the antigens. Okay, so this is correct. Excellent. So let's look at some important concepts here. So the first one is, why do we want to know these blood groups? So that's because, if you want to give, suppose someone loses a good amount of blood and you want to transfuse, so you have to know whether you can transfuse the right, you have to transfuse the right blood to the patient, right? So the reason is, if there is a mismatched transfusion, you get what is called a transfusion reaction, and whenever you have a transfusion reaction, the red blood cells are lysed, so you have hemolysis. And after that, what happens is, when red blood cells rupture, the hemoglobin is liberated. That hemoglobin goes, it's a large protein molecule that can go and clog the filtration membrane in the kidney. So you can end up with kidney problems. So there could be kidney failure. You could have clots forming in different areas. So that's why you never want to give anybody the wrong kind of blood group. So let's look at how we can determine who can transfuse to whom. So let's see. And I'm just going to use another page. So let's say we are transfusing blood, and if you read the slide, you will notice that when you transfuse, the person who is donating blood is called the donor, and the person who is receiving blood is known as the recipient. Now, like all of us, whenever we donate, we are not all that generous. You are not, I'm sure none of you would be willing to donate all of your blood, right? So all you're going to do is a little bit of blood. So the person who's receiving has to be satisfied with what they're getting, okay? Who would be a recipient? Someone who's lost blood. Like you gave an example, like hemophilia, for example, if they've bled a lot and then they need to receive blood. So you have about 4 to 5 liters of blood in you. So usually when you lose blood, even if you lose 500 ml, that's a lot. So, you still have a lot remaining inside. So that means you have a lot of red cells, but you also have a lot of plasma. The recipient has a lot of plasma left in them, okay? So the plasma in the recipient becomes very important. Why? Because what is present in the plasma? Antibodies. So the recipient's plasma is very important. How about the donor? So like I said, the donor is a little stingy, doesn't want to give too much, just gives a little, a pint or so. So here in that you have cells and you have plasma. But you're mainly worried about the cells. The idea why you're giving blood to a person is because if you have lost blood, what has happened? Your oxygen carrying capacity has decreased, isn't it? So when you donate blood, you want to bring their oxygen carrying capacity back to normal. What is one of the most important things which determines oxygen carrying capacity? The red blood cells and the hemoglobin present inside. So therefore, their cells are very important, and of these cells, the red cells are very important, right? So because the cells are more, and you give, I know you can give fractions of plasma and only platelets and so on, but we are talking about just simple blood transfusion. So the donor's cells are very important, and what do cells contain? The antigen. And the recipient's plasma is important because they have a lot of plasma left behind which has antibodies. So you have to make sure that this antigen and these antibodies do not react. Because if there's a reaction, then that's when you'll get a transfusion reaction. So we'll first do the ABO and then we'll look at the RH. Now obviously a person with the same group can always donate to someone with the same group. So an A person who has A will be able to donate to A. Like I said, we are not going to do the RH for the time being. B to B, AB to AB, and O to O. But let's see who else they can donate to. So let's say if this person is A group. Okay? So they have antigen A. And let's say this person is B group. The recipient is B. You cannot donate A to B. The reason is because he's B group, he or she, what antibody do they have? They have antibody A in their plasma, isn't it? If they are B group, that means they have B antigen but antibody A. Now you donate A group to them, what will happen? This antibody will react with this and there will be a transfusion reaction. Got that? So same way, B group will not be able to donate to to A group. Followed? Let's say so the A can donate to A, they cannot donate to B group. Let's see if they can donate. So now I'm going to change this and say this person is AB group. What antibodies are present in someone who's AB in the plasma? None, right? So there are no antibodies. If there are no antibodies, you can give anything to them, right? So A can donate to AB. So in other words, AB can receive from any group because they don't have any antibodies. They will never react with A. They will never react with B. They won't react with AB. Obviously, they won't even react with O. Followed that? Okay. So that's why AB group is often called the universal recipient. And here too, a true universal recipient, I'll just tell you. Now let's say O group. Suppose this person is O group. What antibodies are present in their plasma? A and B both. So they have both A and B. So A group cannot give blood to them because the A antibody would react. Right? So they cannot give, so O group cannot even get from B. They cannot even get from AB. You notice because they have both the antibodies. So if any of these groups were to donate to them, they would react with all of them, right? So O group cannot receive from anyone other than their own group, the O group. However, O group can donate to anyone, and let's see why. So suppose here you have O group as the donor. Remember, in the donor, we are worried about the antigen. So O group, what antigen does the O group have? No antigen, right? So if they have no antigen, it doesn't matter what antibody you have over here, it cannot react with anything. Do you notice that? So O therefore can give, of course, to O, but they will also be able to give to A, B, and AB. So therefore, O group is known as the universal donor. Have you followed this? Okay. Now this was just the ABO typing. Now I'll use one example for RH typing. So again, we take the donor and we take the recipient. So let's say there is A positive. This person is A positive, and we said that A group could give to A group and could give to AB group, right? From the previous chart, that's what we had, A and AB. Let's say this person is A negative or AB negative. Either one, it doesn't matter. Okay? What happens? This one has antigen A and they have antigen D. Isn't it? This person has antibody B in their plasma. Right? So the first time you give this, the A is fine because A and A is same. But now they have antigen D, which you're giving here. So this is foreign to this group, A negative, because they don't have the antigen. That's why we call them Rh negative. So now they are getting something which they've never seen. So they get this antigen D. The first transfusion is fine. But since the body sees this new thing which they have never seen, the body begins to produce antibodies. When it produces antibodies, we call them antibody D. It takes a while for those antibodies to be formed. Red blood cells typically have a lifespan of 120 days. So after 120 days, they die. So the antibody D takes a while to form. So for 120 days, these cells are safe, because this antibody is still being formed, the antibody D. And, the first transfusion goes fine. But now, since the body did some work, it's got this antibody D stored inside. This is going to last for a very, very long time. So we say now such a person is sensitized. Sensitized means that now they can sense and they have the antibodies to this Rh positive. If, again, by mistake, you give them A positive blood, what will happen? The second and the subsequent transfusions, the A part is fine. But now this positive goes here. They have antibody D. This antibody D will react and it will kill off the cell. So they'll have hemolysis. So you'll have a transfusion reaction the second and subsequent times. Can you see that? So you never donate positive blood to a negative person. Someone who is positive, you never donate positive to negative. Rh positive is never donated to an Rh negative person. Okay? However, if someone is Rh, so donor and recipient, if someone is Rh negative, so suppose now we change it. This one is Rh negative. And here, let's say, I have this person as A positive or even AB positive or even AB negative. It doesn't matter. If they are negative, AB group, remember, can get from A group because they have no antibodies. And here the negative and the negative matches, so they are fine. Negative blood can be donated to the matching positive groups because if they are negative, that means they do not have no Rh antigen. So if they have no Rh antigen, when someone is positive, they are not going to provoke anything. They don't have antigen and you're only worried about the antigen. If they don't have the antigen here as the recipient, it doesn't matter. They are the same. Can you see that? So negative blood can be donated to a positive person, but positive blood can never be donated or should never be donated to a negative person as far as possible. So from this you can see that an O negative is a true universal donor. Right? Remember, O was, I said universal donor, but O negative is truly the universal donor if you take, because negative, O positive cannot give to someone who's O negative. They can only give to the positive groups. And AB positive is known as the universal recipient. Because remember, a negative person cannot get positive blood, but a positive person can get blood from negative and positive. So therefore, AB positive is universal recipient and O negative is a universal donor. Okay? Using this, we talk of something known as Rh incompatibility. these ABO, the ABO antibodies, they're very large antibodies and usually do not cross the placental barrier. So if a woman is pregnant, so if she is, say, A group and the child is B group, you don't have any problem because the antibodies do not cross the placental barrier. So there is no blood-to-blood connection between the, interaction between the mother and the fetus. Rh antibodies, however, do cross the placental barrier. So we are always worried about that. So let's say, for example, the mother is Rh negative. So the mother is Rh negative. It doesn't matter which group she is. And the baby is Rh positive. Again, it doesn't matter what, otherwise their groups don't have to match because you're not doing a blood transfusion for them here. And as I said, the antibodies don't cross over. The ABO antibodies don't cross. But let's say the baby is Rh positive and the mother is Rh negative. In the first pregnancy, throughout the pregnancy, everything is fine because, like I said, there is no blood-to-blood interaction. There's no mixing of maternal and fetal blood. But at labor, when the baby is born and the placenta is sheared, then the uterine wall, the placenta sort of is just removed from the uterine wall. The uterus is bleeding at that time. The venous sinuses in the uterus are open. Some of those fetal blood cells, they go into the mother. So these all have this positive antigen. So it's like she's received a donation of positive cells. So now she begins to form antibodies. So she will form anti-D antibodies. What happens? The first pregnancy is fine. Remember I said, so she becomes sensitized here. If you don't do anything, if you let her be, next time she gets pregnant, and she again, say she carries an Rh positive fetus. Now when this fetus is present, because I told you the D antibodies are very small, they can cross the placental barrier and through the umbilical cord, because she takes time to form this. That's why the first pregnancy is okay. So through the umbilicus and the placenta, now these D antibodies will pass through and they begin to attack the cells. And they kill the red blood cells and cause hemolysis. And what happens is all the cells, it can be a very, very severe reaction, in which case you get what is known as erythroblastosis fetalis. Erythro meaning red blood cell, blastosis means they are ruptured in the fetus. So it's called erythroblastosis fetalis. So when those red cells are ruptured, the hemoglobin pigment is liberated. That can go and actually lodge in the brain and in a certain part of the brain called basal ganglia. And it causes problems because it causes something known as kernicterus. So the basal ganglia get affected. The cells are destroyed. So the child most of the time might be stillborn. So this is a major problem that can happen. But it's preventable. Because we know that the mother is Rh negative. You always take the blood, you type her when she gets pregnant, you type and group her blood when she's pregnant. So if the mother is Rh negative, she's carrying an Rh positive fetus, just before labor and definitely after labor, within 72 hours, what happens is that these positive cells, you have to assume those positive cells have gotten into her body, right? You give her something known as ROGAM. These are manufactured antibody D. So what is ROGAM is antibody D. So instead of making the body produce this antibody D, you are giving her these ready-made antibody D. It's known as immune serum or immunoglobulin, immune serum or immune globulin. So that's what you give her. So why are you giving her antibody D? Her body is going to produce it and cause problems. Why do you want to give it and, you may cause problems? The reason you do this is that you're giving it to her ready-made. So it's not going to last forever. What it does is, since you're giving her this antibody D, it interacts with these cells and which have come in and destroys them immediately before they can provoke a reaction. So now there is no reaction which is provoked. She does not produce antibodies. and her next pregnancy is normal. But after every pregnancy, you have to keep giving her RhoGAM. Understood that? It's like, when your parents give you a car, you don't take care of it. Within 2 or 3 years, you have dings, all kinds of things. When you buy your own car, you take real good care of it. Same way, you give them ready-made antibodies, last for a very short time. When the body has to produce its own antibodies, it will last much longer. Okay? Okay, so let's, so we were, so that's what happens. So I explained the incompatibility, and I told you about the antibody molecules, how, the antibody molecules are, ABO are small, so they don't cross the placental barrier. The RH antibodies are much larger. And antigens A and B are actually even secreted in the saliva. This fact of giving transfusion, because you can have so many problems with transfusion, you have an option that we can have. Suppose you're going up for elective surgery. Because, transfusions also not only the reaction, but, if you get transfused with compatible blood, but that blood may have some viral disease in it. So you might, be transfused with that. That's how AIDS was spread in some cases. So now there's a situation which is known as autologous transfusion, where if you're going to have elective surgery 1 month from now or 2 months from now, what you do is you go and donate your blood, and it is stored in the blood bank. Your body makes up that blood, and then when you have surgery, you get donated with your own blood. Should you lose enough blood during surgery and you need a blood transfusion, what they do is they transfuse your own blood back to you. So there's no question of mismatched transfusion. There's no question of spreading anything because it's your own blood. So this is known as autologous transfusion. Auto meaning self. So you're transfusing to your own self. If you do not require enough blood, they won't transfuse that blood to you. This is what is used by people who do something known as blood doping. And you may have heard of the Lance Armstrong scandal, how, he took blood transfusion. The purpose is, what they do is that they remove their blood, it's stored, and then during an event, their body makes up their blood. During an event, they retransfuse themselves with the same blood. So what they do is they create polycythemia. See, they have not lost any blood, but they're kind of retransfusing themselves. So they create a kind of artificial polycythemia. And why are they doing that? Because the more red cells you have, the more your oxygen carrying capacity. So the more your endurance. You see that? But it could be fatal, because if you have polycythemia and you transfuse yourself, those cells are too many. So your blood becomes really thick. So it could go and form clots somewhere. So it is kind of a tricky situation to be in. And so that's the purpose behind how people started using this blood doping. Okay. So let's look at some questions here. Ashley is A and B negative. She needs a blood transfusion. Who do you think she can receive blood from? On all blood groups who are AB or who are negative. Remember, AB was the universal recipient, but negative can only receive from negative. You never give positive blood to a negative person. Okay, so from all groups who are negative, she can receive. Okay, would you be concerned about RH incompatibility if the mother was RH positive? Remember, I told you about the RH, the mother is negative. If she is positive, do you think you would be concerned about RH incompatibility? No, remember again the same thing. A positive person can receive negative blood and positive blood, right? So you're not worried. If she is positive, she has the antigen. So if the antigen goes into her, it doesn't matter. If it doesn't go, again, it doesn't matter. So you're not worried if she is positive. It's only if she's negative, because you don't want positive blood to go into her, okay? This I told you that it increases the oxygen carrying capacity of the blood, so that's why athletes even consider blood doping. Okay, so